So we want to transition next to another practitioner. Scott Centorino is a senior fellow at the Foundation for Government Accountability, where he focuses on welfare and healthcare reform policies that promote opportunities for more Americans. Prior to joining FGA, Scott served as an assistant attorney general with the Louisiana Department of Justice, representing the Department of Health and the Department of Children and Family Services. Apart from FGA, Scott is a captain in the United States Army Reserve, serving as a judge advocate in the JAG Corps. He also operates Red Door Consulting, which has provided policy analysis and speechwriting services to presidents, governors, senators, and nonprofits across America. Scott graduated from Washington and Lee University and received his JD from Wake Forest University School of Law. Scott today is going to be talking to us about how different Americans experience the healthcare system. Just as a heads up, following his presentation, you'll have an opportunity to spend some time in smaller group discussions. So please be writing down your questions or thoughts as you hear Scott present this morning. You can feel free to throw them in the chat if you'd like, or just bring them to the small group discussions. So following this session, you're actually going to leave the webinar and you're going to join the Zoom meeting that's next on the agenda. You'll be assigned to a breakout group. So with that, Scott, I'm going to turn it over to you.
Thanks, Josh. I may not have been governor of Wisconsin or run for president or have a famous name, but my audio and video is working. So that counts in my favor, I think, right now. Well, good to be with everyone. It's good to talk about this very important subject, as Josh said. Let's just dive on in. Needles and scalpels, biopsies and plasma, good news and bad news. Holding the hand of a nervous husband, holding the hand of a nervous daughter, holding the hand of a nervous parent who once held your hand. A wedge issue, a political hot potato, a right or a good. Healthcare is heavy for everyone. In politics and policy, healthcare might be the only issue that actually scares political consultants and policymakers as much as the average voter. It also remains in the top 3 issues every election after election. It's top of mind for small businesses and patients. And as Josh has alluded to, it's going to bankrupt our country without reform. As he said, it's not an overstatement to say that fixing our healthcare system is needed to fix our economic future. So this session is called Who the Health Cares? Medicaid, Markets, and Medicare, or as I like to call it, Meet the McDowells. During our time together here, we're going to follow a small American family that I'm calling the McDowells as they navigate the world of government and private healthcare coverage in America. They're going to go through Medicaid, the private markets, and Medicare. But before we dive in, I want you to take a moment with me. Imagine you're driving on the interstate and you pull over for some gas. When you pull over from the interstate, there are a bunch of gas stations at the exit. Which gas station do you go to? If you take a moment in the chat, let me know if the primary factor in choosing a gas station is the price of gas. Just type Y if that's the primary factor for choosing a gas station, and type N if it's not, if it's some other factor. I'll give you a minute to type in here. Looks like chat was temporarily disabled, but I think it's back online here. Okay, so I know for myself, it is the primary factor, and it looks like for most of you as well. Let's dig even deeper into this topic. When you fill up your tank at a gas station, how much do you pay, and how much does your car insurance pay? So we've got a poll question here. I think Josh has loaded it up for us. Do you pay 20% of your gas bill, with car insurance paying 80%? Do you pay 40% with car insurance paying the rest? Do you pay 75%? Or do you pay your entire gas bill? When you pull off the interstate, you swipe your card. Are you on the hook for the entire bill yourself and don't get any help from your car insurance? Yeah, that's what I thought. I'm going to give people one more moment here to enter their answers. Yeah, so I think pretty much everybody's in the same boat here. Your car insurance doesn't pay anything toward your gas. And it's true for other things too. When you go in for an oil change, how much do you pay and how much does your car insurance pay? Think about it. You pay 100%. Your car insurance doesn't pay for your oil change. In car insurance, you pay for everything that's routine. Your car insurance company only pays for something that's unexpected or catastrophic. That's how most insurance works. Now, on top of that, imagine if no gas stations had prices listed on those signs you're used to. Just none at all. Let's say those signs didn't exist. Would it surprise you if the price of gas on one side of the street ended up being 1,000% higher than the price of gas on the other side of the street? If you had a system like that? Now, on top of that, one step further, imagine if your car insurance company was the primary payer for whichever gas you got on whichever side of the street. How much would you care about the price of gas? You pay the same amount in premiums no matter which you get, and your car insurance picks up the bill. What I just described, that's how our current healthcare system works in America. And it's frustrating because, to continue the analogy for just one more moment, we might have some of the best gasoline in the world. That is, we have the best healthcare. We have really high quality healthcare in the United States, but we cover it up with this broken layer of quote unquote health insurance through a market that doesn't act like a real market. If it's not obvious already, health insurance does not work like normal other insurance. Sure, it does cover catastrophic events, but when someone just goes in for an annual physical or gets blood work or gets inoculations before they travel or has a routine mammogram, they also show their health insurance card. That's not insurance. It'd be more accurate to call it a payment processing system. Okay, so let's meet the McDowells now that we've got that out of the way. I say all of that as we meet them, this American family, to say this: healthcare comes up in American politics, and when it comes up, about 90% of the time, it isn't about healthcare at all. It's about these healthcare payment processing systems we call insurance, and whether to put more or fewer people into markets, more or fewer people into Medicaid, more or fewer people into Medicare, and how those payment processing systems should work. Okay, we're going to now follow the McDowells. This is a fictional family I've created just to show you the process of being in these programs and what it looks like for individuals in these different situations. I think you'll get a sense by the end of this what these programs look like, what these markets look like, and what some of the trade-offs involved in each of them are. Okay, so I'll give you a sneak preview. I'll put the bottom line up front here and tell you what I think the 3 overall takeaways are from the story we're about to tell you, and then we'll actually tell you the story. So takeaway number 1, our system is not uniform. A person's healthcare experience is driven in large part by a person's health insurance coverage. So that's takeaway number 1. Takeaway number 2, this current system that we just described briefly and we're about to go into more deeply, it was not designed to be the way it is. It's not part of a plan. Medicaid and Medicare were built piecemeal over time and not particularly coherently either. And the remaining market, as a result, isn't really a market at all. It's just kind of the leftovers from that mess. And then big takeaway number 3 is, in part because it is a mess, it's going to change. Big reforms, aka opportunities for young people and professionals trying to get into this space, big reforms are coming. And America will soon be forced to choose. They'll have to choose, this country will have to choose a path, either a more comprehensive government takeover or a more genuine, real market-based solution. So those are the 3 big takeaways. Now let's go ahead and actually meet the McDowells, and we'll follow them through this system. So Lucy McDowell is a single mom who lives with her 2 kids, Chris and Allison. They live in the Overbrook neighborhood in Pittsburgh, Pennsylvania. Let's talk about Lucy first. Lucy is a very healthy 39-year-old woman. Health-wise, really the only thing that she deals with on a regular basis is a mild case of epilepsy. Occasionally she has seizures, but it's a chronic condition and she's able to manage it pretty well with a prescription medication. She works part-time. She works about 25 hours a week as a cashier at the Giant Eagle supermarket. It's about 10 minutes away from where they live. And she earns, while working as a cashier there, she earns about $28,000 a year. The job does not come with health insurance. That's the last thing I'll say about Lucy for now. Okay, so that's Lucy. Allison is 13 years old. She was born with spina bifida, and she's paralyzed from the waist down. Luckily, she's got very few neurological problems from her spina bifida, and it's led her to be able to carry on a pretty active life. She's relatively normal in most aspects other than being paralyzed from the waist down. She races other kids in her wheelchair, and she pets every dog she meets. She's leading a pretty good life in dealing with her spina bifida. Finally, Chris is 8 years old. And other than being a little addicted to video games, he's entirely healthy. Okay, so those are the McDowells right now. Here's a pop quiz that I didn't warn you about. I guess that's the definition of a pop quiz. Based on what you know, where are these folks when it comes to where they get their health insurance? I actually won't make you type this in the chat, so you're off the hook. Do you think, just think in your own mind, are these folks in the market? Are they in Medicaid? Or are they in Medicare? Just answer to yourself for a moment where you think these folks would be. So right now, the McDowells are a Medicaid family. And before we get any further, let's get one kind of important thing out of the way: the difference between Medicaid and Medicare. If you leave this presentation remembering only one thing, and it's the basic difference between Medicaid and Medicare, you will be ahead of 90% of the public and probably about half of the policymakers I work with. So let's get that done right now. And I'll give you a way to remember. It's kind of a dumb way to remember, but it's so dumb that it's memorable. It's one of those. It's how I remembered most easily. So Medicaid is just for low-income Americans. And you can remember that with the aid at the end. Medicaid is aid for the needy. Medicare is for all seniors. That's its primary purpose. We're going to get to some other stuff Medicare does, but Medicare primarily serves all seniors. And you can remember that because Medicare ends with an E, as in elderly. So Medicaid as in aid for the needy, Medicare with an E at the end as in elderly. I know it's dumb, but it might be so dumb you can remember it. All right, so because the McDowells are a Medicaid family right now, let's go ahead and dive one layer deeper into Medicaid, and we'll go through what that program looks like. So all three are eligible for Medicaid. And we're going to talk about why right now. Technically, Allison and Chris are covered by CHIP. That stands for Children's Health Insurance Program. But that's more of a 201 or 301 level topic. And just suffice for our purposes, CHIP is an arm of Medicaid. So let's talk about why these three individuals are on Medicaid, what that means for them, and what that means for America. Medicaid is a joint federal state program. And again, as I said before, it's designed to cover low-income Americans. In 1965, when the National Medicaid program was formally created, it was designed to cover low-income Americans specifically who had long-term healthcare needs. So individuals like folks with disabilities, seniors, and kids. Those were the groups that Medicaid was originally designed to cover. So that's, in short, why Allison and Chris are eligible. And we'll go one layer deeper now again. So Allison is eligible for Medicaid because she's on Social Security income, or SSI for short. She's on SSI because her disability makes her eligible for SSI. And because she's on Social Security income, any individual on SSI is eligible for Medicaid automatically. So that's why Allison is on Medicaid and why she's eligible. Chris is eligible for a different reason. Chris is eligible because his household income, $28,000, that's what Lucy makes at the grocery store, is low enough that even though Chris doesn't have a disability, he's eligible just as a child in a low-income household. So that's why Chris is eligible for Medicaid. Last but not least, what about Lucy? Why is Lucy on Medicaid? Well, over time, Medicaid has been expanded to more and more able-bodied adults. The biggest expansion obviously coming with Obamacare in 2010. And Obamacare, as you all probably remember and know, made it a state option for states to expand Medicaid to able-bodied adults who were at 133% of the federal poverty level or below. And again, most states now have opted into expansion. There are a little over 10 states that have not, but most states have. Lucy, we mentioned that Lucy has a chronic condition, that epilepsy, but she's still able-bodied. She's not on disability. She's not collecting anything because of that chronic condition. But her income, $28,000, is low enough to qualify for Medicaid through expansion. She lives in Pennsylvania, which has expanded Medicaid, so that's why she's on Medicaid. Okay, a few other things on Medicaid. First, it's big, and this is a big point. So let's get a chat question going here. I mentioned that it's big. Let's actually put some numbers on this. We've got about 330 million Americans in this country. How many of them, and you can type it in the chat, how many of them do you think are on Medicaid? So out of 330 million Americans, how many are enrolled in this program for low-income Americans? I'll give you a moment. Getting a lot of pretty good answers here. See 80 million, 40 million, 100 million, 50 million, 80 million, 75 million, not quite 100 million. So the answer is not quite 100 million. That's exactly right. We're above 90 million at this point. We're about to cross the threshold of 100 million. So out of 330 million Americans, we've got almost 100 million on Medicaid, which is stunning for a lot of reasons. Another thing to note about Medicaid is it's got this really unique government dynamic between the federal and state governments. It's a very unique federal-state push-pull dynamic. A little bit more than half the money comes from the federal government, and the other half comes from state governments, like in the McDowell's case, Pennsylvania. And then here, let's do another poll question here. How much of Pennsylvania's state budget do you think is spent on Medicaid? What percentage of Pennsylvania's state budget is spent on Medicaid? Just trying to give you a sense for how big this program actually is. I'll give you a moment to vote on that. By the way, this is one of the questions that most stuns policymakers and the public alike, the public in particular. A lot of state legislators know this number all too well. They are haunted by this number in their dreams, but the public is stunned when you give them this number. Right now, we're sticking to Pennsylvania, but this is true across the board. So in Pennsylvania, I'll give you the answer. It's about 40% of Pennsylvania's state budget is taken up by Medicaid. Yeah, so even in this pretty educated group, you kind of underestimated. There were a few folks who got it and went over, but it's a pretty stunning number. About 40% of Pennsylvania's state budget is taken up by Medicaid, more than public education, more than public safety, more than infrastructure. So you can imagine that as that piece of the state budget grows, Josh used the term Pac-Manning earlier. It's true. Medicaid has Pac-Man resources from other programs because it's kind of on this automatic entitlement track. States have a very hard time reining that in, and so they end up taking funds away from other programs. It's a huge line item. It's the biggest single line item in every single state budget, in fact. Some states less than Pennsylvania, but they're all, in every state, Medicaid is the single biggest line item in the budget. Okay, so that's kind of Medicaid's fiscal picture. What does being on Medicaid actually mean for the McDowells, though? I promise sort of a personal touch, give you a sense of what these programs work like for the people on them. What does it mean for the McDowells? Well, two things primarily. First, there's no time limit and no work requirement either. So if Lucy at the grocery store gets fired, or she decides to stop working, or if she just stayed at the same income level for 10 years without a change, her Medicaid coverage remains. It's very stable. It's very static. It's there. So that's first. Second, there are trade-offs in that coverage. This is a theme you'll hear again and again here, that there are trade-offs with everything. We all know that intuitively. For taxpayers, there's the trade-off that the McDowells have no incentive to shop around on the basis of affordability. It's like they're going to gas stations and the prices are marked off. Their health care bills are pretty much entirely paid for by Medicaid, no matter what they do. The other trade-off is that even though the McDowells have this relatively stable coverage that doesn't go anywhere, the patient experience is pretty poor. Fewer and fewer healthcare providers accept Medicaid patients. And it's pretty easy to explain why. The program pays providers at certain reimbursement rates for certain services, and those rates are pretty significantly lower than what the providers charge patients with private coverage. So again, back to our gas station analogy, imagine if you're running a gas station. If people pull up into the gas station and they're on Medicaid, and anybody who's on Medicaid, you can only charge $1.50 to, even though the listed price on your sign is $4. How long would you allow people with Medicaid to come into your gas station if you could choose who came in and who didn't? So fewer providers are accepting Medicaid patients, and fewer providers overall means less access to healthcare for people on Medicaid. And yet, at the same time, the cost of Medicaid is growing and growing and growing. So again, you can see already the trade-offs that we're talking about here. Quick political question. I know that nobody on this call would be crass enough to think about political implications in any of this, but how do you think Pennsylvania the state thinks about this family right now, the McDowells. What do the McDowells mean for the state in terms of cost? Well, here's where it gets a little tricky, but it's a 101, so I promise some education here, so I'll deliver. It's actually different depending on the family member. So Pennsylvania, as a state, gets a different federal match rate for Allison and Chris than it gets for Lucy. For Allison and Chris, Pennsylvania gets about 65 cents from the feds for every dollar Pennsylvania spends on them. But when Pennsylvania spends $1 on Lucy, Pennsylvania gets 90 cents from the feds. Why? Why would they get more money for providing coverage to an able-bodied adult than to a child with a disability like Allison? Well, in a word, at least everybody's least favorite word for 12 years in this space, Obamacare. Obamacare. Under Obamacare, the federal government gave states, again, the option to expand Medicaid to able-bodied adults. They encouraged states to do so with that much higher federal match rate of 90 cents per dollar. Pretty pernicious, right? Okay, so what are the big takeaways here on Medicaid before we move on? Well, number one, again, just big takeaways. Number one, it's big, both in terms of enrollment and spending. That's in large part because Medicaid has been expanded beyond its original core purpose, which was, again, long-term coverage for people with long-term needs, but it has never been reformed to reflect that expansion. It has never been reformed to reflect that expansion. Big takeaway number two is the program, again, has that unique federal-state push-pull dynamic. And as a result, it's kind of Pac-Manning resources from other state priorities. And then big takeaway number three, the patient experience is poor because fewer and fewer providers accept patients with Medicaid. Okay, that's Medicaid. That's 101 for Medicaid. Let's move forward in time. Lucy gets some good news at the grocery store. Lucy gets a raise at Giant Eagle. I'm told, by the way, by Pennsylvanians that Giant Eagle is like the local grocery store in Pennsylvania. So I'm going on faith on that. At Giant Eagle, Lucy makes about $38,000 a year now. She had been making $28,000, now she's making $38,000 a year. But she's still not offered employer-sponsored coverage. So what does that raise to $38,000 a year? What does that higher income mean for the family's healthcare coverage? Does it change anything? Well, let's go one by one. For Allison, not really. She's still eligible for Medicaid because her disability keeps her on SSI. That's just an automatic thing. What about Chris and Lucy? Well, that new income puts the household at about 160% of the federal poverty level. And with that higher income, Lucy is no longer eligible for Medicaid in either the able-bodied expansion category or the parent caretaker category. So Lucy, is now shifting from Medicaid to the market. In her case, she's going into the individual market, which is part of the health insurance market where individuals are buying their own healthcare plans rather than signing up through their employer. So Lucy, in her case, will use the exchange in Pennsylvania that was set up by Obamacare in which to purchase a plan. And by the way, she'll receive extremely generous subsidies as she does so, i.e. a check to insurance companies to cover her premiums. She'll have a low premium, and in fact, right now, she'll have no premium. At her income level, the federal government under current law is paying the entire premium. So it's essentially free but private coverage through the individual market for her right now. But in normal times, if the current law expires on schedule, in normal times, she may end up paying some very modest deductibles and copays on that individual insurance plan. What about Chris, though? Even though Lucy is now ineligible for Medicaid because of the higher income, Chris is still eligible for Medicaid. See, the income limits for kids are higher than they are for adults. So even though it's obviously the adult's income that is being counted, the McDowell household income is still low enough for him, Chris, the son, to qualify for Medicaid. In fact, the McDowells could earn up to almost $70,000, and Chris would still be eligible for Medicaid. I'll summarize a very long story on why that is. Politics. Kids are popular. That is why Medicaid for adults is still more or less a welfare program. But for kids, Medicaid has become a kind of middle-class entitlement. Okay. Let's fast forward just a few more years. Allison has graduated from high school, but she still lives with her mother. To help her mom out and earn a little bit of spending money herself, she works part-time in the back office at a local veterinary hospital. Remember I mentioned she likes dogs? It's coming full circle. She works at a local vet hospital. Chris, meanwhile, has graduated high school as well. He's going to college, Penn State, still plays too many video games, but he's doing really well and is a business major and is on track. What about Lucy? Well, she's doing pretty well too at this stage. She was offered a promotion at Giant Eagle. She's now a full-time assistant manager. And now that Chris is out of the house, she can accept that kind of a job. She can work full-time. She's now making $48,000 a year. So what does this change about all of the McDowell's healthcare coverage now? Well, for Allison, again, not much. Her coverage is amazingly stable. She's still eligible for SSI, supplemental security income, and she's therefore still automatically eligible for Medicaid. If she was able to work more, she might eventually earn enough income to disqualify her from SSI and Medicaid, at which point, like Lucy, we just talked about her, she'd then become eligible for either subsidies on the private individual market, or if she got a job with health insurance, she could get on that. But she's not in that boat at this point. For Lucy, as a full-time manager or full-time assistant manager, Giant Eagle grocery store now offers Lucy a health insurance plan as part of her job benefits. But at $48,000 per year, she would still qualify for subsidies on the exchange in the individual market. So another chat question coming your way. Just feel free to type right there in the chat. What do you all think at this point in the story Lucy should do? She was just offered coverage by her employer, but her income is low enough that she qualifies for subsidies on the individual marketplace. So should she take her employer coverage? You can type employer if you think she should do that. Or should she stay on the individual market and continue to collect subsidized coverage? And you can just type individual or individual market for that. So I'll give you a moment here to type in what you think the answer should be. I see one employer, I see an individual one. Employer, individual. No. Cost is being asked. That is a good question. I think Kim wants more information than I'm willing to give at this point. Another employer. We get split down the middle here. We have a tie-breaking vote. Kim, you might have to commit with the information you have. I'm kind of asking you to guess what the cost difference is, which you think is more cost effective. All right, so Kim's going with employer. Any other guesses here? Where do you think Lucy should go? Employer sponsored coverage or individual market? All right, looks like the balance is tipping slightly toward employer coverage. Give you one more moment. Oh, one more individual market. All right. It's a hot topic, clearly. All right, so I have to confess, it's a little bit of a trick question. You're only eligible for the subsidized plans on the exchange, the individual market, if you have not been offered coverage by your employer that's deemed affordable. So she's really generally required by law to go into the employer-sponsored coverage. This is all part of the Obamacare vast fabric of the individual market that Obamacare created. So again, Lucy doesn't have an option really. She has to take the employer-sponsored coverage. She's kicked off of her individual market plan as soon as she's offered that coverage through her employer. For the vast, vast majority of Americans who are not on Medicaid or Medicare, this new coverage that Lucy's on, this employer-sponsored coverage, that's how most Americans get their healthcare coverage. In fact, when Lucy received coverage previously on the individual market, she was in a group that constitutes less than 10% of Americans, even though most of our political fights and most of Obamacare was over that sliver of the private market. Why? Why is it that most Americans get their coverage through employer-sponsored coverage? Well, the short version is that most folks who don't work at all, who are under 65, are on Medicaid. Most folks who do work get coverage through their employer, again, if they offer it. But more and more employers have stopped offering coverage because of those generous taxpayer subsidies through Obamacare that we've just covered. When it comes to employer-sponsored coverage, most of the folks on this training session, you all probably understand what this looks like from a patient experience perspective. You pay monthly premiums, and generally speaking, the higher the premium, the lower the deductible. That is, if you pay more on a regular monthly basis in premiums, if you go get healthcare, your insurance company will pay more of the bill. If you pay them less monthly, you'll be responsible for more when you get care. That's the general way that those kind of employer-sponsored coverage plans work. And again, as we discussed earlier, people expect to use these private plans whenever they get care, even routine care. So for Lucy, that means using her insurance card when she has her annual physical, when she goes to urgent care if she has a stomach bug, and when she refills her regular prescription for epilepsy. As you remember, she has epilepsy. Whenever she refills that prescription, she's using her insurance card. Insurance, I'll read the subtext out loud if necessary. Insurance usually means pooling risk and sharing that risk so that no one person who gets really stuck with a bad situation ends up suffering really badly. But this scheme, this health insurance scheme, even in the private market, is not sharing risk. It's prepaid healthcare. We will all use healthcare services. And so that means higher premiums for everyone because it's a healthcare payment processing system more than it is insurance in that sense. So just one last thing on employer-sponsored health insurance before we move on. This is a really basic question. It's one of my favorite questions to ask people new to this space. Why is this even a thing, employer-sponsored coverage? What is this? Why is our health insurance so attached to our job? I mean, when we get a new job, we don't switch car insurance. We don't switch home insurance. Why are we switching insurance plans based on employers? It doesn't happen in any other context. Well, it's a few reasons. One reason is that employers, especially big employers, they have more bargaining power than sole individuals because they can pool costs more effectively among a bigger group. Another kind of interesting historical reason is it's actually kind of a unique outgrowth of the worker shortage that occurred during World War II. At that time during the war, employers were prohibited from offering wage increases as they were competing for workers. But companies figured out that you could compete based on these add-on benefits, one of them being health insurance. And so companies would offer jobs with health insurance, even though the pay was the same as their competitors, and workers could choose the company based on that health insurance. So it's kind of an outgrowth of that unique historical circumstance during World War II. But honestly, more than that, as interesting as it is, At this point, the biggest reason for employer-sponsored coverage being so dominant within the private marketplace is, like anything, taxes. So in part because of that World War II experience and that being kind of baked into the cake of employment arrangements, Congress grew to like the idea of employers offering insurance to workers. It was pretty convenient for them. So what they did was, in the tax code, they built this really unique carve out so that the money both an employer and an employee pay toward private health insurance premiums is treated totally differently than other money. It's an exclusion. It's not just a deduction, but it's an exclusion. It's more heavily favored in our tax code than even a charitable contribution. The IRS at no point touches that money. So it's very unique in our tax code. It's put at the top of a pyramid above a lot of other things. Okay, so that was a small but important digression, I think, on employer-sponsored coverage. Let's get back to the McDowells for a moment. We talked about Lucy, but we didn't talk about Chris yet. Well, Chris, as I said, he's graduated high school. He's at Penn State now. He's doing well. He's still Lucy's dependent. And where is he? Well, under Obamacare, as most of you probably remember or know, plans must cover dependents up to the age of 26, whether those plans are in the individual market or their employer-sponsored coverage. So Lucy's plan, it's now employer-sponsored coverage, must cover Chris. He's under 26, he's a dependent of hers, so he is still on Lucy's employer-sponsored private plan. Okay, so we've just gone through the private market, as far as it is a market. What are the big takeaways for the private healthcare market in America before we move on to the final subject here? Well, big takeaway number one is even this private market doesn't work like a real market because most payments are processed through insurance rather than just catastrophic events, as we've discussed a couple times now. That's big takeaway number one. Big takeaway number two is within the private market, the individual market is much smaller than the employer-sponsored coverage market. But the individual market gets much more attention, in part because the government just is a little bit more free to fiddle with it than the employer-sponsored coverage market. So employer-sponsored coverage, much bigger than the individual market, but the political attention is kind of in reverse. Third big takeaway, our tax code explains the structure of most of the private market. And this kind of undergirds a bigger takeaway that we mentioned at the outset here, which was this healthcare market that we have in America now was not created intentionally this way or coherently. These things just kind of snowballed over time and gave us the system we have now. And then the fourth and final takeaway in this private market is that the patient's experience is mixed. The payments to doctors are higher. So when the McDowells migrate into private health insurance and on that commercial insurance, they get more access because more doctors take that form of insurance. But the health outcomes, even in the private market, are still very uneven. The total cost is still very high. And the McDowells, as pretty much everybody on this call knows, even if you have private insurance, you're never totally 100% confident of what you're responsible for when you walk into an urgent care or a doctor's office or a hospital. And you're not entirely confident what your insurance company is responsible for. Medical bills are still a mess in that system. Okay, so those are the big takeaways in the private health insurance market. Let's fast forward one last time, another decade or two this time. And where does everyone stand now in the McDowell family? Well, Chris, after graduating Penn State, came home to Pittsburgh. He started his own family, and he's a marketing executive at one of Pittsburgh's biggest companies. Anybody know, by the way, what industry Pittsburgh has become known for now? I'll give you a hint. It's not steel or ketchup. Anybody know? Trevor saying health insurance. That's exactly right. I'd say healthcare more broadly, not only health insurance, but they've got a lot of innovative healthcare companies as well. It's one of the top healthcare hubs in America. So let's just say Chris, now that he's graduated with his business degree, he goes to work at Highmark, which is one of the big health insurance companies headquartered in Pittsburgh. One of his benefits, not surprisingly, of working at Highmark is he has access to a pretty good employer-sponsored coverage plan through Highmark. So we've already talked about employer-sponsored coverage, but just one more thing on it since we're following Chris at this moment. Now that he's on the insurance company side of this trajectory, Chris learns, now that he's working there, that when he was young, growing up with both Lucy and Allison in the house, when he was young, he was part of what's called crowding out. So basically what that means is that the more people that enroll into Medicaid, and Medicare for that matter, the more people that enroll into those government plans, the fewer people are left to be on private insurance. And when you have fewer people left in private insurance plans, that pool of risk gets smaller and smaller and smaller. And the premiums of the people left get higher and higher and higher. Why? Well, it's because Medicaid and Medicare have set prices, or reimbursement rates is the technical term. And Medicaid and Medicare, they pay providers less than private insurance. And so what do providers do? Well, they charge patients with private insurance more to cover that difference in cost. And that cost, of course, as you'd expect, gets passed along to individuals in the private health insurance market through higher premiums. So politically, it's this awful vicious circle where the people who are on private insurance, this smaller and smaller group, see their premiums going up and up and up, and they clamor for more government intervention and more expansions of these government programs, and the cycle continues more and more. What about Lucy and Allison? They live on the other side of town now. Chris is at Highmark. Let's catch up with where they are in their lives. Well, Lucy is now in her late 60s. Allison, for her part, she still lives with her mom, but something interesting happened since we last checked in on Allison. For a few years, she was doing really well health-wise, so well, in fact, that she was able to become the office manager at that veterinary hospital I mentioned. She was working full-time. She got employer-sponsored coverage, the whole 9 yards. But then, unfortunately, Allison's condition really deteriorated, and she had to stop working entirely. Where are these two now, Lucy and Allison, and their healthcare coverage? Both, interestingly, now qualify for Medicare. Lucy, because of her age, again, that's what Medicare was primarily designed for, to provide coverage for all seniors, regardless of income. Unlike Medicaid, it's not designed to be a welfare program targeting low-income Americans only. Medicare is designed to cover seniors at all income levels. It's the only type of insurance pretty much every American will have at some point. But Allison is on Medicare for a different reason. She's not a senior yet. She's on Medicare now because of her disability, the same disability that made her previously eligible for Medicaid. So why is there a difference here? Well, here's the last little bit of true, maybe 201 level nuance for you. When Allison was growing up, she was on SSI, Supplemental Security Income. And SSI is designed for people who have never been able to work. And that program made her automatically eligible for Medicaid. Now that Allison worked for a few years, she's actually eligible for something different. She's now eligible for Social Security disability insurance, or disability in common vernacular. That's what most people call it, just disability. SSDI is the more common acronym among wonky nerds like me. When Allison qualifies for disability now, she actually gets, in addition to the disability payments that come in as a former worker, she's now eligible for Medicare. It's this thing in our federal law where people who have work history tend to get treated a little bit better with this distinction than people who've never worked before. So if you have a work history and you get on disability, you're put on Medicare. But if you never worked and you're on SSI, you get put in Medicaid. Okay, so that's a little bit of nuance there, but I think it's worth mentioning even at this level. So in terms of experience for Allison and Lucy, what does this mean now that they're on Medicare? Well, the high-level version of what Medicare looks like is that Medicare is divided into 4 sections or parts. And very creative people in the government gave these 4 parts very creative names. They're Part A, Part B, Part C, and Part D. It's pretty stunning work, I know. So Medicare Part A is the original Medicare. It primarily covers inpatient services, so hospital care, some home care, and hospice care. When Allison and Lucy, the folks we're kind of following right now, tracking, when they receive those services through Medicare, they might pay a small copay, and that's it. Under Medicare Part B, that part of Medicare covers doctor's bills, outpatient services, screenings, lab tests, and medical supplies. When Lucy and Allison receive coverage through Medicare Part A, they might pay a small premium for that coverage. So something like $100 a month or $150 a month. So Part A, a little bit of a small copay. Part B, small premium per month, and they cover different services. All right, here's where it gets really interesting. Medicare Part C, it's also known as Medicare Advantage, is a different system entirely. So Medicare Part C basically allows seniors to opt out of Medicare Part A and Medicare Part B and instead go into this subsidized private insurance plan or a managed care plan. And those plans usually cover similar or often more services than what Parts A and B cover. By the way, it's worth noting politically, Medicare Advantage is enormously popular, and it's growing much faster than the other parts of this Medicare system. Seniors, obviously, unsurprisingly, like choice, and they like the different options for coverage, and that's why it's so fast growing. And then finally, Medicare Part D, this is the newest section of all, obviously, that's why it's last. Medicare Part D is all about prescription drugs. It looks a little bit like Part C. Hey, how are you? Looks a little bit like Part C in that Medicare enrollees choose a private insurance plan that receives government subsidies, and then the senior then pays monthly premiums based on income. I should note that there's a caveat here. If either Lucy or Allison end up needing nursing home care, that kind of long-term support service is actually covered through Medicaid, not Medicare. I think this is explicitly designed to confuse people. So if you don't retain this, it's okay. But this is unique. So when they go into a nursing home, they will become what's called dual beneficiaries or dual eligibles because they receive coverage through both programs. That's all I'll say about this to spare you from more heartache. Like Medicaid, Medicare, one of the takeaways here is that Medicare is big. Over 60 million Americans are enrolled in Medicare, and almost $700 billion is spent per year on that program. And much like Medicaid, it's also unsustainable as it's currently designed. Medicare, as you might imagine, based on these numbers, is on track to be insolvent in the later part of this decade. The payroll taxes just are not covering the costs of the program. And that means one thing that everybody on this call can finish this sentence. It means either taxes will go up or reform to cut costs will be forced on Congress, period. In other words, this is another way to think about it. Most of the action in healthcare reform in the last 20 years has centered around Medicaid. But the era of Medicare reform might be just around the corner. We might be right on the cusp of big Medicare reforms. Whether Congress wants it or not, they're going to be forced to deal with this problem pretty soon. Okay, let's hit the big takeaways for Medicare before we wrap this up, and then we'll separate out into the breakout sessions here. Okay, Medicare takeaways. Takeaway number one, it's fiscally unsustainable. So big reforms are coming. Like it or not, they're coming. Big takeaway number two, the power of market-based reforms in healthcare is pretty powerfully illustrated by Medicare Part C. We have something we can point to, in other words, to show that markets do work in healthcare. But of course, Medicare Part C is not a silver bullet. It's not solving every problem. So we haven't gone far enough yet. And then finally, number three, big takeaway number three in Medicare is that from a patient's perspective, the experience is still pretty mixed. The payment rates to doctors are between Medicaid's low reimbursement rates and private insurance higher reimbursement rates. And access is okay, much better than Medicaid, in part because there are so many folks on Medicare that access services so often that most providers kind of consider taking Medicare a necessity. It's almost like they're running a gas station and every other driver on the road gets gas through that program. So they don't consider it all that optional to turn people away. The health outcomes, just like everything else we've talked about here, are uneven. And as we said, the total cost of the program is high and growing higher every year and unsustainably. So that, in a very quick nutshell, is markets, Medicaid, and Medicare.